everyone. My name is Tony Urbanek, and I am really pleased to make this presentation for you today. Unfortunately, I don't get to see who I'm talking to. It's always nice to see faces and views when I'm talking to a group. But in any case, I have a lot to say and a lot to teach in a very short amount of time here in 50 minutes. But we will get through it, and I hope that you are able to really get a totally different viewpoint on the temporomandibular joint problem. I'm well aware of what has been going on in the treatment of TMD for the past literally 45 years since I've been in practice. So first, let me tell you a little bit about myself very briefly. I am a double degree oromaxillofacial surgeon practicing in the Nashville, Tennessee area, Middle Tennessee, for the past 46 years. I started my academic career in Cleveland, Ohio at John Carroll University, a little Jesuit school whose claim to fame is that Don Shula started his coaching career at John Carroll. Pretty much most of you may know that Don Shula is the winningest coach in football history in the United States. I went from there down up to Indiana University School of Dentistry in Indianapolis and received my dental degree and also a master's degree in anatomy and cell biology. From there, I came down to Nashville, Tennessee, and matriculated at Vanderbilt with a special program that included a medical degree, internship and residency in oral maxillofacial surgery. And toward the end of that, I was also awarded a 2-year fellowship with the NIH to do my own independent research project on facial growth and development. And at the end, I had decided to go into private practice. I was gearing for an academic career, but right at the end, I decided private practice. And for the past 46 years, I've been practicing in Nashville. So with that said, as a primer, we can proceed to talk about the TMD conundrum explained and TMD demystified. And it has been a mystery. It has been a mystery to me, and it has been a mystery to many over the years. So let's start out just talking about some basics. I'm going to go through, I know that I'm told this is a worldwide group that is listening, mostly in the United States, I'm sure. But let's define a few terms first. I'm going to gear the first part of this to basic information. I know some of you, this will be old stuff, and for some of you, it may be totally new. But let's do the basic stuff first. So let's define, first of all, what is TMD? TMD actually is a disparate array of confusing symptoms, and that's what has everybody in a twit about this problem for the past 50 years. It's a disparate array of confusing symptoms. Now, we're going to spend a little time on this slide, and you will see this slide again. We're going to make many points about this slide, but these are the common symptoms that are included in the concept of TMD. Frequent or recurring headaches, frequent or recurring earaches, neck pain, jaw pain, ringing in the ears, tinnitus, subjective hearing loss, which is described by most patients as fullness in the ears, where it feels like they're got water in their ears and they can't hear because the ears are full. Dizziness, vertigo, and the difference between vertigo and dizziness, there's not much difference except vertigo is constant dizziness and dizziness is intermittent dizziness. Upper shoulder and arm pain, which is a new symptom that not many people know about, and we'll talk about that toward the end. Arm, hand, finger tingling and numbness, which is the same, and various types of and degrees of jaw locking. So those are the actual symptoms. There are others that are not as common, but these are the common ones. What is the incidence of TMD? Well, actually, the incidence is much more than most people think. Most studies show, and I'll tell you why. Most studies only focus on the most common, which is headaches, earaches, jaw pain, and don't include the other symptoms that we just noted. When you include ringing, fullness, dizziness, which is nothing more than Meniere's disease, and a few others, that incidence goes up quite a bit and actually is 45% of the female population in the United States between ages 13 and 75. If you do the math on that, that works out to 76 million females. Now, we know it's heavily weighted to females. In my observation, it's 95% females, 5% males. But we're dealing with primarily the female population, and 76 million women in the United States have one or more significant symptoms associated with TMD. This answers a question that I get often from my patients and other doctors, and it is like, I did a survey with probably a dozen of my oral and maxillofacial colleagues a couple years ago, and I said, is this problem all females? And everyone agreed, yeah, it's 95% females. I said, why is it females? Everybody shook their head and rolled their eyes. Well, here's the answer. It's been in the literature for 50 years. Why is TMD almost exclusively female disease? It's because of this one fact: estrogen exacerbates inflammation. And we're going to talk a lot about inflammation here in a few minutes. If you want to learn about estrogen and inflammation, I just put a reference here at the bottom. You can look it up. And it's a very good reference talking all about estrogen exacerbates inflammation. Let's do a little bit of the basic anatomy. I promised you we had to go through some basic stuff first. So this is the basics on the temporomandibular joint. Almost everyone probably knows this. You got the disc, you got the condyle, you got the glenoid fossa, you have the articular tubercle, and this joint is billed out as a very special joint. We'll talk about that a little bit, but it's really not so special. That's the one problem that we have from the get-go about TMD, is that we all were taught in dental school that this joint is really special, and it's so unique and so special, probably nobody will figure it out. Well, that's not true. But the point is, here's the general anatomy, and as this joint opens up, first 25 millimeters of opening is through a rotation, and then the last 25 millimeters is through a translation or a glide along the tubercle, and it pulls the tissue forward. And pretty much that's really all you need to know about the temporomandibular joint and the normal anatomy and how it works. As it glides forward, it moves against the tubercle with the meniscus and then rotates on the condyle. Now, a couple things about discs. Now, one of the misconceptions, and I'm not going to spend much time on misconceptions. We're going to talk about actually the meat of this. But one of the misconceptions for a long time, and I bought into it as a surgeon. As a surgeon, I did the first 30 years of my career, I did temporomandibular joint surgery. And I did, in those 30 years, over 2,000 temporomandibular joint surgeries. All of them had something to do with that disc. Half of those surgeries were what we call open joint surgeries, where I did an incision and did various things within the joint itself, and half of them through an arthroscope. But the point being, the reducing disc has always been thought to be a huge problem with temporomandibular joint issues. Well, here's just a view of what is a reducing disc. The disc gets loose under the influence of inflammation. We'll bring that word out early. Under the influence of inflammation, which loosens the attachments, the disc comes forward, and then once the condyle comes down the slope enough, it'll reduce back or click back, usually with a louder noise and some pain. If you see any TMJ patients in your practice or any familiarity, you're familiar with this problem. And then the non-reducing disc is similar, but it doesn't reduce, it doesn't click back, and now you end up with a lock, what we call a closed lock, where you get halfway open, 2/3 of the way open, quarter way open, and the disc is in the way. It doesn't click back, it doesn't reduce, and now you can't open your mouth all the way. So what are the accepted causes of TMD? Now, there are only 3, and they all have a common factor to them. And I think all of you are familiar with these, or you should be, except the last one in the list, and we'll talk about that a little bit. But first of all, the most common, admittedly, is clenching and grinding. It makes no difference whether it's a clench or a grind. It's all the same thing. Bruxism creates damage which creates chronic inflammation. Keep that in mind. Acute trauma can be all kind of things, 4x4s off the back of pickup trucks, bar fights, beer bottles to the face. I've treated all of those multiple times, but acute trauma eventually ends up with chronic inflammation. And then functional malocclusion, as a maxillofacial surgeon, I treated literally probably a couple thousand cases of orthognathic surgical cases, including major prognathisms, retrognathia, big open bites. And what I didn't appreciate about functional malocclusions were the types of malocclusions that were significant COCR or centric occlusion, centric relation discrepancies. What I found, within the past 10 years is that you do not have to have a significant, when I say significant, half inch, I'm talking a couple millimeters. If you have a couple millimeters of difference between CO and CR, sometimes that is enough functional malocclusion to create significant damage to the temporomandibular joint, thus creating what? Chronic inflammation. So what all these accepted causes of TMD have in common is chronic inflammation. And that'll be much more clear in the future, in a few minutes. So all the known causes of TMD create inflammation within the temporomandibular joint. The common denominator for all the disparate symptoms is inflammation within the temporomandibular joint. Now, the real issue of the title of this is, the solution for this is, and we're going to show it and prove it and explain it to you in detail. It is inflammation within the temporomandibular joint itself that creates each and every one of the symptoms that I went through. I'll repeat that. Inflammation causes each and every one of those symptoms. Now, if that is the fact, then if you can decrease inflammation, you have the problem solved. If inflammation goes away, the symptoms go away. We know that nonsteroidals work really well, and that's a fact, but nonsteroidals will only work for a short time, a week or two on nonsteroidals, and all they do is tear up your stomach and they don't work anymore. So a couple words about the basic science of inflammation. And again, this is pretty much common knowledge, but inflammation, and if you recall back to your pathology, has basically 5 characteristics: redness, increased temperature, increased swelling, increased pain, and dysfunction. And of course, doctors have to speak in Latin to be important, so we call them rubor, calor, and tumor, and dolor. But really, technically, from a scientific, from a cell biologist point of view, it is a cascade of cellular and exudative components, including fibrin, immunoglobulins, leukocytes, especially cytokines. I may mention cytokines and emphasize that later on. Cytokines, neutrophils, monophils, T cells, B cells, mast cells, histamines, and macrophages. Now, those are some of the major components of inflammation. The first thing that y'all need to really understand is we don't know everything we should know and can know about inflammation. We know a lot about inflammation. There's a lot of great science going on about inflammation. Inflammation is the body's response to heal. If you have inflammation, it is the body's response to fix something that's broken, that shouldn't be there. And it applies to just about every type of problem. All right, so let's go through these again. These are the common symptoms: headaches, earaches, neck pain, jaw pain, ringing, fullness, dizziness, shoulder pain, arm, hand, finger tingling, and numbness. And we're going to talk about how each of these symptoms is directly related to inflammation within the temporomandibular joint. If you can make the inflammation go away, you can make all these symptoms go away. So how can the disparate symptoms be explained? That was my puzzle. Here's the story. And this is, I've told this story, oh my God, thousands of times, I guess. After 30 years of doing temporomandibular joint surgery, one weekend I was really disappointed over a couple things that had happened in the office, and I thought it through the weekend. And I came in on a Monday morning and I announced to my staff that we weren't going to see TMJ patients for surgery anymore. This was about 12 years ago. The results I had some good results, and I had some results, an increasing number of results, that after, no matter what kind of surgery I did, and I did them all, I did many, many, many kinds of surgery. After a year or two or less, they'd be back in the office with the same symptoms. So I announced on a Monday morning that we weren't going to do surgery anymore. And I had a large practice. I really saw the vast majority of TMJ surgery in Nashville. And I was doing 2 or 3 cases of just TMJ surgery a week, along with everything else that I was doing. At the same time, literally at the same moment, I had decided that if I'm going to stop doing surgery, I need to try to figure out what nobody else could figure out about this thing, because I knew that surgery was not the answer. I knew that night guards was not the answer. I knew that everything else that everyone had applied to this problem was really not the solution. So I decided, because of my research background, which was very broad and very extensive, that I was going to see if I could figure this out. So instead of going back to the textbooks and the clinics and the congresses and doing what others said to do was the right thing, I decided to go back to the patient. And I had lots of TMJ patients, so I brought a line of those patients in over a period of about 4 months. I interviewed 24 patients with TMD that had between 10 and 20 years history of headache, earache, jaw pain, etc. And I sit down there with them and I say, I'm going to sit here as long as you want to talk, and I want to know all about it. I want you to tell me everything that you know about this problem. What do your husband think about it? What do you think about it? What makes it better? What makes it worse? What phase of the moon is it? What kind of weather happens when it hurts? Does the dog bark when it hurts? And I would sit there sometimes for 30 or 40 minutes and expect these ladies to tell me what's going on. And it was very, very interesting that my patients actually gave me the key that opened the door that solved this puzzle. They gave me the key. And the key was this: out of those 24 patients, at least half of them said something along this line. If I take a pencil or a pencil eraser or my tongue or a piece of cloth or my finger and gently put it between my front teeth, it feels better. After hearing that multiple times, the light bulb went off, and I went in my office, my little lab, and I made a device that separated the back teeth and only the front teeth touched. And I gave it to one of the first women in that series, and who had 20 years of pain. And I said, put this in your mouth, keep it in 24/7, because I designed it myself so that you could use it 24/7. You could speak with it in your mouth. You couldn't chew with it in your mouth, but you could speak with it in your mouth. You could drink fluids, hot and cold fluids. But I gave it to the first woman, and I said, put it in your mouth, keep it in 24/7, come back in 3 weeks, except when you eat. She came back in 3 weeks. I walked in the room and I said, how you doing? And she said, thanks, doc, my pain is gone. Now, this was a patient who literally had 20 plus years of headache, earache, jaw pain, neck pain. And I was stunned. And I think she saw I think she saw my face as to why I was stunned. Is like, weren't you expecting this? And, I wasn't expecting it. Now, this little picture, I got to tell you about this picture. So this is not one of those ladies that I was talking about. This happens to be a patient that I saw about 2 years ago. And I'm doing a consult, which we do 60 to 80 TMD consults a month. And she was sitting in the chair. And as I was asking questions and getting her history of symptoms, I noted this little thing she had on a string around her neck. And I was kind of suspicious of actually what it was. But after I finished my survey for symptoms, I said, what is that around your neck? And she says, well, that's the thing that keeps me sane. I said, really? I said, that keeps you sane? She says, yeah. I said, what do you do with it? And she showed me. She puts it in between her front teeth. So that just makes the point. There is a large group of people out there who actually figured it out before I figured it out. If you put something between your front teeth and gently bite down, it feels better. So this was the first device. This was not the first one I made, but this is basically a rendition of the first device. Very simple. Fits in the palate, has an anterior pad, has no guidance at all. It's a flat pad, and it had a couple ball clasps because I thought that was the best way to keep retention into the maxilla. And here's how it looks in the mouth. This was the original design with the original patent and made by Dental Lab. Now, here are the puzzle pieces. So I did, we did one patient, had these fantastic results. Not everybody comes in at 3 weeks and says 100% of their symptoms are gone, but we now know that the average, after treating 4,000 patients in this practice, and we have network providers throughout the United States of their own practices, but 4,000 patients in this practice, after the first 24 patients, I did not know how this thing worked. All I knew is it worked. So I went back to the drawing board and I did a few thought experiments, and these actually are the puzzle pieces. These are the legs of the three-legged stool that supports why solving the problem of chronic inflammation within the temporomandibular joint makes all the symptoms go away. First is something we were all taught in dental school. That is 90% of the loads on the temporomandibular joint originate from the posterior teeth. I've never told that to a dentist and he doesn't agree with me. Yeah, that's basically what we learned in dental school. Number two, I touched on already, 100% of the tissue samples, 100% of the time, chronic inflammation within temporomandibular joint problems. But every time I did a surgery, part of that surgical process on those 2,000 cases, part of that was take a tissue sample and send it to pathology. And the report came back in a few days. And each report, each and every 100% of the time, when I did 2,000 surgeries on these joints, came back as chronic inflammation. Now, the third leg of this stool actually is not known except to our orthopedic colleagues. And our orthopedic colleagues call this issue or call this phenomenon. It's not a phenomenon. It's a physiologic, neurologic entity. They call it joint splinting. And we're going to spend a little time because this is the heart and the meat of really what you need to learn about. I didn't create anything. I didn't create anything new. I just found some things that were already in the literature and well known, put them together, and it explained the whole process. So we're going to talk a little bit about joint splinting from the orthopedic point of view. And the best way to explain that is something that you all might be familiar with called tennis elbow. Tennis elbow, I'm explaining it to you very rapidly here. Tennis elbow is nothing more, nothing less than the lateral epicondyle of the humerus, which is that little button right there, gets inflamed when you rotate and move the forearm rhythmically back and forth too long, too much. And what happens is the attachments, the ligament attachments and the muscle attachments to this lateral epicondyle become inflamed and they break down and they cause chronic inflammation. Now, here's the phenomenon that the orthopedic surgeons taught me when I did my orthopedic rotation at Vanderbilt University in the 70s. And that is, when this epicondyle becomes inflamed, it sends an autonomic signal, an autonomic nervous system signal, basically the sympathetic part of the autonomic, the fight or flight part of the autonomic nervous system. It sends a signal up to the central nervous system at the level of the brainstem. Doesn't go higher. You don't know this is going on. It's the autonomic nervous system. It sends a signal through the system that says, I'm inflamed. The central nervous system at the level of the brainstem gets that signal, and it basically modulates it, and it says, I'll help you out. Don't move that joint. And it sends another signal down through the system, the autonomic nervous system, that says, tighten up. Don't move the joint, to the muscles that move that joint. And so when that occurs, the muscles of the forearm get the signal to tighten up. And when they tighten up, it pulls on the bone, the periosteum. And when it pulls on the periosteum, it stimulates the nociceptors. Those are little histologic entities within the periosteum that actually create the pain. Nociceptors, pain, Latin for pain, nociceptors, which then goes back up to the higher levels of the brain that says, ouch, it hurts. That is tennis elbow. And the major symptoms of tennis elbow is not pain of the lateral epicondyle. The pain people complain about mostly is pain of the forearm, and sometimes going all the way down to the wrist, of pain and burning and numbness. Burning, pain, and numbness of the forearm when the inflammation actually is in the lateral epicondyle. Now, that is the orthopedic explanation of joint splinting. Now, maybe some of you are ahead of me in this thought process here, but when I realized that this fact that all joints work the same way, and that's where we got led astray in our academic career from the very get-go about TMJ problems. They were told this is a special joint and it's so special and it's so unique. That's a lie. It is not special and unique. It operates like any other joint under the same symptoms and the same autonomic symptoms, the same pathological mechanisms go on. And when you compare tennis elbow to temporomandibular joint problems, they are identical. They're just different joints. So the phenomenon, we're going to go through this again because I really want you to get this. This is the meat of what I have to teach and why this device that we had to call the urbanic device, because I wouldn't call it what my patients wanted to call it, the miracle device or save my life device. I couldn't do it. Phenomenon of joint splitting, inflamed lateral epicondyle, whether it be the elbow or the TMJ, but afferent transmission of the presence of inflammation back to the central nervous system. After that, the efferent transmission from the central nervous system to the muscles that activate the joint. In this case, with the TMJ, it'll be activation of the temporalis and masseter and mediolateral pterygoid, et cetera. And those muscles will get tight, and they will pull on the bone, and they will stimulate the nociceptors, and they'll have different kinds of headaches at different points of time, unilateral, bilateral, and it goes on for months and years. Most everybody thinks they have migraine headaches. Muscle developed trismus, and then the muscle pulls on the nociceptors, and off and running, you now have all kinds of different facial pains, Again, just another way of describing it, the afferent sympathetics come down and innervate this area. The signal goes up to the brain, back down to the muscles, and the muscles get tight, pull on the bone, and they will describe pain. Oh, I have so many pain right here at the mylohyoid. Well, how in the heck can inflammation in this joint cause pain down here? Well, that's how it causes. This muscle gets tight, pulls on the bone, and now you have people complaining of pain underneath their chin or at the angle of the mandible, or almost 100% of the time at the coronoid process. Now, the interesting phenomenon now is if it isn't fixed, if you don't get rid of this inflammation within the temporomandibular joint, one way or another, the signals keep getting back up to the central nervous system, up to the brainstem. It says, hey, we're inflamed. This is inflammation down here in the joint. And the brainstem says, well, I told you don't move the jaw. Now what I want you to do is hold the whole head still. And patients will complain next of neck pain. The neck pain is the second most common symptom of TMD, for sure. Second most symptom is neck pain, and they will point right to the insertion of the muscles of the neck, the trapezius or the sternocleidomastoid. They'll put the finger on the mastoid process and say it hurts there every morning. I know a lot of you have seen this. I'm certain of it. You've witnessed that for yourself. Then really fascinating, I was into this now about 200 cases, and a patient came in and told me, you know, Dr. Urbanik, thanks so much. My headaches, some earaches are gone, but does this have anything to do with my arm, hand, finger tingling and numbness? Because that's gone too, and that was just driving me nuts. And I went, I've never heard of that before. And I filed it away, and about 2 months later, another patient comes in and basically says the same thing. You know, arm, hand, finger tingling and numbness. That sent me back to the books. And that was easy to explain once I thought about it for just a few minutes. Once the signals come back to tighten up the muscles of the neck, especially the scalenes, and in the upper shoulder area also, it squeezes down on the brachial plexus. It just squeezes the brachial plexus. Squeeze the brachial plexus long enough, it's going to create pain and numbness and tingling all along its tract of the arm, forearm, and frequently finger tingling and numbness. We see that fairly frequently. So it's not magic. Inflammation in the TMJ causes all of these symptoms. The device itself does nothing more, nothing less than take the load off the joint itself, and all the tissues within the joint, like a set of crutches, would take the load off the knees. Decreasing the load within the temporomandibular joint decreases the inflammation. Sooner or later, the inflammation gradually decreases and the symptoms gradually diminish and go away. It is that simple. It is that simple. Now, let's go through this a little further now. So we've covered some of these symptoms already fairly well. The ones in white: headaches, neck pain, jaw pain, shoulder pain, arm, hand, finger tingling, and numbness. Next up is frequent or recurring earaches. I don't know how many thousands of people have come in here that have frequent or recurrent earaches. They've gone to their PCP or they go to the walk-in clinics and they either get one of two things. Either they say there's nothing wrong with your ears, or they get a prescription for antibiotic, about 50-50. None of them have any problem with the ear itself or the tympanic membrane. All of those people have inflammation of the external auditory canal. Well, how does that happen? Well, let's go to this little slide directly out of Gray's Anatomy. And again, remember, I'm a trained anatomist and cell biologist, so I had the opportunity to have the basic broad knowledge on this for the get-go. So, you know, the temporomandibular joint is juxtaposed to the external auditory canal, but there's really hardly any tissue in between the posterior aspect of the joint itself and the anterior part of the external auditory canal. So when this joint becomes inflamed, it is really easy for the inflammatory fluids, the cytokines, by the way, look it up. Cytokines are nothing more than secretions from some of the cells of inflammation to create influence on other kinds of cells. So, you know, inflammation isn't just a bunch of cells. Inflammation is also the secretions from those cells, which have effects on other cells within the inflammatory system. But the point being, inflammation in this joint caused by the three basic problems, bruxism, acute trauma, and functional malocclusion, will eventually seep through the, very thin, it can be cartilage, very little bone, if any, and tissue into, from the inside out, a mucosa, or actually skin at this point, skin of the external auditory canal, and create earaches. It hurts. Now we have. Let's go back here a slide. I want to make sure I make this point very clear. So we have covered now how inflammation causes all those in white, how it causes earaches. We're left with here a couple more. Tinnitus, subjective hearing loss, which is fullness in the ears, and vertigo. The definition of Meniere's disease is, the ENT definition of Meniere's disease is the symptoms themselves: tinnitus, subjective hearing loss, and vertigo. How in the heck can you get tinnitus, subjective hearing loss, and vertigo from inflammation within the glenoid fossa, within the joint? Well, actually, that's best described on that joint that we just left. It doesn't take a rocket science to go to the anatomy itself and find that there's a fissure. It's called a petrotympanic fissure. It is literally a highway from the posterior part of the glenoid fossa directly into the middle ear. Now, let me go to the next slide. So it's called petrotympanic fissure. There, you can see it right there. This is directly out of Gray's Anatomy. Let me orient you on this. This is the next slide, directly out of Gray's Anatomy. You're standing inside the middle ear, looking out. You're in the middle ear now, looking at the tympanic membrane. But here actually is the petrotympanic fissure. It's also called the Glaserian fissure because it was Dr. Glasser in 1869 that actually found and named this fissure. So this has been around a long time, but it actually allows inflammatory fluids, exudates, and cytokines of different kinds, and certainly change in pH into the middle ear. And what's in the middle ear? Your hearing mechanism and your vestibular mechanism. It just so happens that the chorda tympani, and to remind you about your anatomy, chorda tympani supplies taste to the tongue coming off of the facial nerve. Chorda tympani comes through the Glaserian petrotympanic fissure. So nerve comes through it, and inflammatory fluids come the opposite way and create, when they make the changes in the middle ear, ringing, fullness, dizziness. So now we have these three handled. We have the solution to some, I don't claim 100%. We'll never claim 100% unless it can be proven. But we see literally out of 4,000 people, at least half of those people have one or more of these symptoms, which diminish or go away when you make the inflammation in the joint go away. So we have this handled directly from inflammation in the joint. We only have one left, which is various types of degrees of jaw locking. That has to do with synovial fluid. How does the jaw lock? And there's a lot to say about this. I have a podcast that I do on Dental Town each week. Every week I do it one, and I did one on synovial fluid several months ago. Did the whole episode, 30-minute episode on synovial fluid. But the basic is that under the influence of chronic inflammation, synovial fluid becomes sticky. You know, synovial fluid is supposed to be like oil. It's supposed to lubricate the joint. Well, it loses its lubricating properties. It becomes sticky like glue. And now when that meniscus gets loose and the ligaments get loose, literally it's pushed forward and sticks. That's really what makes it sticky. The synovial fluid itself is not lubricating anymore. And that's why it goes forward. It isn't pulled forward. It's pushed forward and then sticks there. So now we have all four of them. We have all of these covered. How inflammation causes directly each of these symptoms. Now, how do you diagnose TMD? Well, that's super easy. You don't need MRIs. You don't need CT scans. First of all, look at each of these symptoms as a red flag. This does not make the diagnosis. This makes you suspicious. If you see one or more, or especially if you see 4, 5, or 6 of them, well, I see one of them, you're suspicious. You see all 10 of them, well, you still don't make the diagnosis off of symptoms. What you do is you do this.
Steps to a self-exam. Step number 1. Place your fingers of both hands in front of your ears where the TMJ is located. You should be able to feel a depression in front of the ear as you open your mouth widely. Step number 2. Open your mouth as wide as possible. You should be able to feel the depression when you open your mouth. Press firmly into the depression, equally on both sides. Step number 3, close your mouth rapidly. If you feel pain on one or both sides, it is highly likely you have TMD, temporomandibular joint disorder. Step.
So that is the exam that you need to do. The exam outcome. If it hurts, the only thing you know is this joint is inflamed, right? If you push on a knee and it hurts, the only thing the orthopedic surgeon knows is the joint's inflamed. You know, the definition of TMD, besides the symptoms themselves, should be inflamed joint. That's the definition of TMD, inflamed joint with symptoms. So if it hurts, the patient has one or more of the symptoms, the patient has TMD. You have the symptoms, you have the diagnosis made. So the protocol is very important. And this device, we call the Urbanic device and protocol, together. You have to follow the protocol. You have to know how to use it. It is a tool to use. You just don't give it to the patient and say, good luck. The protocol is very simple. What we learned after treating, we didn't take 4,000 people to learn this. Over the first few hundred, we learned that the protocol needs to be 24/7 for the first 2 months, and then nighttime for the rest of their lives, nighttime indefinitely. 15% of the patients find they need to wear the device during the day. 85%, that's all I have to do is use it at night, but never 24/7 after the first 2 months for the obvious reason. You can get super eruption of the posterior teeth. I know each and every one of you have already thought about it, asking the question, but I can tell you, you do not get super eruption in an adult with the posterior teeth in 2 months. Doesn't happen. Can happen in younger kids. We do treat younger people, even, lots of adolescents. 16-year-old girls have this problem all the time. You have to be cautious. I always talk to patients, mothers sometimes, about younger patients, and they say, you have to do something. You have to make the pain go away. And I say, well, we may have to bring some orthodontic assistance in here if we start having teeth moving too fast. But in an adult, the protocol is pretty standard, 24/7 for 2 months, nighttime indefinitely after that. You'll find 15% of the patients need to wear it more during the day, and they will tell you consistently, I figured out I need to put this in when I'm in traffic, and I put it in my mouth if I'm sitting on the computer clenching and grinding my teeth. So that was the original device, and since then, just recently within the past year, because of the availability of technology, we learned how to make this thing. This is still the original design, patented design. We now make it CAD/CAM. It's made on a computer, and it is 3D printed. And it works just as well. Same thing. I mean, all you're doing is separating the back teeth without interference, and kind of looks like that in a model. For sure. Now, to be fair about devices that distract or separate the posterior teeth, I want to be fair and balanced. There are, to my knowledge, 3 other devices that separate the posterior teeth. I want to bring them out. Number 1 is the Coist device. Some of you may be familiar with the Coist. It's used primarily for determining centric relation in certain diagnostic occlusal reasons. That's very common, the Coist device. It has this little, a nubbin in the middle of it, which contacts the mandibular incisors. It separates posterior teeth. To my knowledge, it is not used for temporomandibular joint treatment. Might be, but that is the Coist device. There's another device called the Quick Splint, or I knew it as a Quick Splint. They now call it the Speed to Treat device. Actually, it's a device that is used only for temporary treatment, but it does separate the posterior teeth. I'm not sure whether it's a boil and block or whether they mix material in there, but it has a tray, and you put the material in and cover the maxillary teeth, and you can't use it very long. You can't use it very much, as you would expect, but that is another device that separates posterior teeth. And The one that's most common is the NTI. The NTI has certain characteristics that are not harmonious with speech, for sure. You can't wear it 24/7. You can't talk with it in your mouth, but it does separate the posterior teeth. And I'm sure that some of you have had experience with the NTI. I see many patients bring their NTI in to see me. Their primary complaint is it is kind of traumatic on the front teeth, but what I hear mostly is it won't stay in place. But I don't want to be critical. I'm just saying this is a device that does separate the posterior teeth. And if you separate the posterior teeth long enough, according to a proper protocol with care, you will get the inflammation to diminish in the temporomandibular joint. When the inflammation goes away, the symptoms go away. The advantage of the device over all the other potential options or treatments, I've listed them here on the right. I'm going to let you read those for yourself, but this is everything I could think of. Maybe you have experience with doing some other things for temporomandibular joint or hearing about other things that have been used. But I have seen many patients who have used each and every one of these. The advantage of the device and protocol is no drugs, no drug side effects, very long-term results, as long as you're following the protocol, because you're going to use it every night. You're going to keep the inflammation away. Once the inflammation goes away, you're going to keep it away by using it nightly. Simple treatment. It addresses, and here's the most important feature, it addresses all of the symptoms simultaneously. You're not just injecting a simple muscle with Botox. Yeah, you can paralyze a muscle. If the muscle hurts, you can paralyze it, and that muscle won't tighten up anymore. It won't pull on the nociceptors, and it will not hurt. But what about the ring and fullness dizziness? What about the locking? What about any of the other symptoms? Well, if you go back to the common denominator and decrease the symptom, you decrease the actual common denominator, which is inflammation, you address all the TMD symptoms simultaneously. It's the least expensive. Our independent university study proved that. No surgery or downtime, no surgical complications, no recurrent care using the protocol. Once the protocol begins, the patient controls treatment themselves. They use it. If they need to wear it more during the day, they can. If they don't need to, they don't have to. And you're treating all of the symptoms. And it's proven, as I stated, by an independent study. Again, the advantages versus other devices that disocclude the posterior teeth. This is the big one. You can speak with it in your mouth. You can wear it 24/7. You have a specified treatment protocol. It has excellent retention and stability, excellent retention. It's adjustable when needed. I don't want to go too deep into vertical dimension. That's also in the Dental Town podcast. We talk extensively about, on occasion, vertical dimension needs to be changed. It's aesthetically pleasing. It lasts indefinitely when cared for with basic toothbrush and toothpaste. Keep it in a case. Lifelong provider support. And it also comes with continued CE training opportunities and integrated marketing and referral awareness program. It is independent university studied, and access to the white paper is available to anyone who asks for it. The white paper is complete. We can send it to you, and the two actual papers that have been submitted to peer-reviewed journals, I'm told one is ready to come out, actually publish in 2 months, and the other should publish sometime this year. So long-term effectiveness, we know we have long-term effectiveness because I get to see patients who have had this thing in their mouth now for 6, 8, 10 years, and they come back and they lose it, they break it. I just left question marks. I will not comment. I don't have enough knowledge to comment on the long-term effectiveness of using an NTI or similar device. So again, we have an independent statistical study. It's available if you'd like to see it. We're happy to send it to you. So I have had the privilege and the honor to change the lives of over 4,000 patients. That is a fact. using a non-surgical device where my first 35 years of my practice did surgery, and I just wanted to solve this problem for the patient. It has truly been an honor and a privilege to come up with this. I didn't, as you can tell, I didn't invent anything. I took knowledge that was out there, has been out there all the time. If you'd like to do the same, here's how. You can request a Zoom. You can visit our website at urbanictmj.com and ask for more information. To become a network provider, you have to take a 3-hour, actually 2.5-hour course. You get 3-hour CME credit, and you have to sign a license because it's patented. And we will be happy to assist you in being a network provider. We have a growing list of network providers throughout the United States now. And I want to see this. I want to see as many women with this problem that devastates their life. I can't tell you the number of women who come in my office with tears in their eyes. And some of them don't come in with tears in their eyes, but they start crying when they even think that there may be a solution to this. They cry just when I say, I can help you. I can make these symptoms go away. So you can email my director of education, also at education and marketing. She is a doctor of education, Dr. Naomi. You can email her. And I can be contacted at my personal email at tony@tmjservices.net. I am giving you my personal phone number, my cell number. Here it is. If you'd like to talk to me, I will take your call. So thank you for your attention very much. I appreciate your attention. I appreciate for those who are here. And I would love to entertain your questions. We have Stephanie. I imagine some of these can be very specific, and I'll try to run through as many of these as I can. We have about 10, 12 minutes to run through questions, and I'm very pleased to answer them. Stephanie asks, when opening and closing TMJ pops but no pain, is that considered TMD? Yes, because that proves that the meniscus is loose. The meniscus can only get loose if there's been inflammation in the joint. Now, inflammation comes and goes. You don't have to have, actually inflammation is cyclical. It's primarily in females, it's cyclical with the estrogen levels. And I don't want to get too deep into estrogen levels. There's a lot more to say about estrogen levels because I've studied it extensively. But the answer is yes, it is considered TMD. Now, you may be asking, do you treat a noisy joint? No, I don't treat a noisy joint. I don't recommend you treat a noisy joint. I recommend that you tell the patient that they have TMD, and when they start to have symptoms, come back and see me. That's what I say routinely. And I see a good number of those. Next one is M. Schwartz. Have you seen changes in the occlusion after using this device for 2 months? Yeah, absolutely. And let me tell you why. And that gets a little deeper, but when you place a patient into a device that separates posterior teeth, the mandible is going to drop back to centric relation. Everybody on the planet has 2 bites, centric occlusion, centric relation. It might be 1/10 of a millimeter, or it could be 1 inch. But everyone, when you put them into that device, is going to drop back to centric relation. And when they drop back to centric relation, you can see, I'll give you the best example. Years ago, I had a 16-year-old girl who learned, because she had such a retruded mandible, to bring her teeth forward intentionally into a centric occlusion, where it brought her chin forward, look pretty, look good. And she came in to see us with terrible TMJ pain. Well, it didn't take but a few minutes for me to figure out that she was holding her mandible forward, and when the mandible dropped back, she not only had a class 2 occlusion and an orthognathic problem, but she had an open bite. So yes, you're going to see different changes from, depending on the degree of COCR difference. Most people can tolerate small difference. They don't even know there's a problem. But the answer to that question is yes, and that's the best way I can explain it. We have Bahan. could aligning teeth to ideal occlusion with Invisalign be a long-term treatment? My fast and dirty answer is no. I have seen so many patients just with orthodontics. I mean, Middle Tennessee is a pretty big place. And over the years, my entire career, but certainly in the past 12 years, we've seen a large number of people who have been recommended to have orthodontic treatment of any kind for their TMJ problems. Theoretically, if you want to go through a couple years of orthodontics to see if you can get CO to equal CR, theoretically that may take enough load off the joint to decrease the inflammation. But if that's all you're counting on to do Invisalign or small tooth movements, I wouldn't count on it. Another way of answering that is when we do orthognathic surgery, and we know that orthognathic surgery was a contributing factor, I tell the patients consistently that it's a 50-50 chance after that we do the orthognathic surgery and the orthodontics that go along with it. And we got a nice bite. CO is close or equal to CR. There's only a 50-50 chance that the symptoms are going to go away. 50% they don't have to have a remake on the device, and 50% do. And I promise you, those 50% come back to the office and get the device. Acacia asks, can we use Vivera retainers with bite ramps on canines? Not familiar with that device at all. I cannot recommend that device because I cannot comment on how that would affect the occlusion. Although one comment I can make is, the anterior six, a mandibular anterior six, do not have to occlude with that anterior, we call it the anterior pad. All teeth don't have to come in contact with that pad. They just have to be bilateral occlusion. And you can have just two canines touching, and the incisors, that are frequently uneven across, they don't have to touch. Next question is from Michael Pollock. Thank you for an excellent and informative presentation. Can the Urbanic appliance be used in TMJ cases where a CT scan shows joint disc deterioration? Absolutely. Look, I only use a Panorex. I don't use CT scans to make a diagnosis. But let me answer this question. I celebrated the 100th episode on Dental Town by taking cases from 2022. And the criteria to pick out these cases were, number one, there were success stories written by the patient. Number two, each Panorex showed severe damage to the temporomandibular joints, to the point that not just me, but any oral or maxillofacial surgeon who still wanted to do surgery on the temporomandibular joint would say, this is a surgical case. So what I did was we found 17 cases from 2022 that had severe joint damage to the point that obviously slam dunk surgery cases. And I presented those cases one at a time, first describing the symptoms of headache, earache, jaw pain, etc. I showed the x-ray and all the severe damage, and then I read the success story. And that's the way I celebrated. I celebrated not only 100 episodes, but I celebrated the fact that you do not have to do surgery or any other treatment other than on the temporomandibular joint on bad disc and disc deterioration, for sure. And I have gone into joints where there hardly was any disc left, or just disc was a piece of putty. We have about 5 minutes to go. Let's see, the next one here is Amanda. Can you please show the list of symptoms again? Well, Amanda, I would suggest you can watch this, watch the webinar again. You can see it there. I don't think it's fair to go back to do that, but you can do the webinar again, and you can see that symptom list. Tracy, who's an RDH, says, my mother is 81 and was recently in the ER for very condition. Thank you. I will be taking your info. Well, thank you, Tracy. I'm sorry about your mom. Believe me, hey, we've treated people in their late 80s and 90s. I just love to see these patients smile after 20, 30 years of pain. Stephanie B says, any connection between birth control and TMD? Well, that gets into estrogen, Stefan, and the answer is basically yes. I'd suggest you delve into the literature because there is information about that. James says, thank you. Thank you, James Baker. Kelsey says, terrific lecture. Thank you, Kelso. Stephanie, how much is the licensing fee for the product? Okay, well, I'll tell you what the business model is. You have to take the course. I have to know that you understand how to use this thing. You have to take that course. The course and the license is $2,200. And you didn't ask, but we have our own manufacturing facility now, which I have total control over. We make just perfect, devices. So the course itself and the license to protect the patent is $2,200, and then each device that you order once you get licensed is $600. Ashley says, are those your oh yes. I have 7 grandchildren now. 7 grandchildren and 1 great grandchild. And I just had another, the 7th grandchild was just born. Her name is Winnie, not Winifred, Winnie. And she is a doll. She is a doll. I enjoy my grandchildren. Van Sprouse says, great lecture. Thank you. Thank you, Van. And Donovan Dichter says, what type of support do you offer for your network providers? Well, we offer all the support you need. We can help you with the technical part. I have a great, Naomi is a great skilled director of marketing and education. She will do everything you need to do to understand how to use it. I'm available, and we also have a in-house marketing program. Let me just 2 seconds about my marketing program. We figured out how to market this to the physicians. I can't explain it to you in 2 minutes, but we figured out how to market it to the physicians, walk-in clinics, PCPs, that misdiagnose these things all the time. And we're using that marketing method, which we're happy to share with you. My practice here, and I'm not exaggerating any of these numbers, has over 800 referral sources out of Middle Tennessee who send us TMD cases. You may not want that many, but we have that available to you, and we have all the support that you would need on an ongoing basis. Let's see here. James Barassa, how is this different from a thicker night guard with anterior occlusion only? Well, if you can, I guess the difference is that you got to be able to wear it. If you can figure out something that doesn't cross the patent that we have, and that the patient can wear 24/7 for at least 2 months, I have no problem with that. I had a patient once looked at me kind of weirdly, kind of glared at me and said, you mean if I can put a pencil eraser between my front teeth, it'll fix this? And I said, yes, ma'am. If you can put a pencil eraser and hold it there for 2 months, I promise you, your pain's going to go away. And I meant it. And she even glared harder at that point. I don't think she liked the answer. Mark says, is there a certain lab that you can send the scans to for fabrication? Yeah, we have our own lab now. It's patented, and we have our own lab right here in Brentwood, Tennessee, in Franklin, Tennessee. That's associated, that's not in my practice, it's a separate facility where we make them ourselves. That's why we have total quality control over it. We used to sub it out. And I think this is going to be the last question here. Maybe we can get one more too. What does the orthodontist do to help with this treatment when needed? Well, if you have, well, for example, let's say you have a COCR problem and it's not too big. Well, I refer to the orthodontist, and the orthodontist will then take out the COCR difference, or if it's a significant COCR problem, then it goes to the orthodontic surgery, the oral maxillofacial surgeon, who teams with an orthodontist. Between the two of them, they take out the problem, the cause, one of the causes, which is what? Functional malocclusion. PB, and this will be our last, PB says any special technique needed for the impression procedure to fabricate the appliance. The answer is no, as long as it's a really good impression. And you have to remember, and we have had problems with our network providers, they're used to taking scans or focusing on their PVS impressions on just the alveolar ridge. We need to see the entire palate, and you need to make sure it's really complete. But there's really no, any technique that gives us a really good impression of the alveolar ridge, and especially the maxillary palate. So with that said, I believe we are finished. If there are any other questions, you're certainly welcome to contact me. I'm happy, or my staff is happy, to answer those. And I, again, appreciate your attendance at this. And I really, really hope in one way or another that it helps you treating patients and helps you in your practice. So for tonight, thank you very much and good evening.